Okay, so here we are back. It is day 4, and we are starting a new topic this week. This week, the topic is on Christian response to humanitarian crises, how to handle fragile settings, emergency response, those sorts of questions. I am really looking forward to this week. There's a lot of this that is very relevant to what we do at MorseCode Medical, and also just getting to hear some of the stories of those who've been doing this a whole lot longer than we have, and some of where they were able to see some of those successes. So first thing I want to point out is 2 out of the 3 speakers today mentioned that they started off in the Peace Corps, that was really where they first got a vision for what working in low resource environments could look like, what their role in international health could be. And I hear that story a lot. I hear that from a lot of people who say, I started off in the Peace Corps, or I started off in this volunteering or that volunteering opportunity as a young adult, and it really stuck with me. And in some cases, it took them a decade or more to get back. It took them 15 years to get back, 20 years to get back. But it really is important, those early adult years of being able to get that exposure to other parts of the world. So I know that is definitely a privilege that not everyone has the opportunity to take advantage of, but if you have an opportunity to see other parts of the world, to get other perspectives, to put yourself in someone else's shoes and to think differently, and to really see how a lot of other parts of the world live, it is absolutely worth it. And I did some traveling when I was a teenager and early adult that definitely informed the way that I made decisions and saw a lot of other discussions and conversations, including those that we're having in our world right now, through having those other experiences. So would highly recommend that. And I love the fact that 2 out of our 3 speakers, really, that was where they got started. So one of the first things I want to talk about from today's session, and I'll put the link below in the YouTube comments so that you can go and watch the whole session if you want to. But one of the things that I found really interesting, and I want to just play this little clip here, is as we talk about COVID-19 and other responses that we have to whether it's a pandemic or whether it's other communicable diseases, but the way that we respond in times of crisis, and really how we need to be careful about what our priorities are versus those of the communities that we're trying to serve. So I'm just going to play this clip real quick, and I want to talk really through what does it look like when we have those situations where maybe our priorities don't align with the priorities of the communities we're in, or where there may be some suspicion about what the support looks like or why we're doing that kind of support. So let's go. We've got this clip here. I'm just going to play for you. And this was in the question with response to how we can learn from what happened during Ebola.
There was a lot of confusion and mistrust in those early days around Ebola messaging. And, people wondered, why do we need all these NGOs and all these various partners in their new vehicles and their uniforms and their containers? Where were they when we were hungry, when we were sick, when we suffered from all kinds of illnesses and no one came? There was a sense that it was the Ebola disease that brought us there, so we could simply make sure that it did not come into our area, cross borders into areas where we were sent from. Mm-hmm. In the end, the Ebola response has cost nearly $1 billion. That's close to $300,000 per victim. But one of the lessons, Debbie, that we learned was not what was important to us, which was of course containing the outbreak, but knowing what was important to the host communities. People were most concerned about schooling for their children, access to food, water, healthcare, safety from the many different militia groups that would go in and out of the area. Ebola was not their main concern. It was ours. And of course, as I mentioned, there was a lot of suspicion and a lot of mistrust. We found that church leaders were the greatest source of our help in terms of messaging and working with the local population.
So one of the things that's really important there that is being pointed out by Bill is this question of why are we there? What are we doing? Why are we helping? And really, are we there for the right reasons? Are we there for something that's really what's desired by the local community? And so as you heard there, when it came to what the biggest concerns were in the community, obviously nobody wanted to die of Ebola. That was obvious, that of course that was important, but it wasn't the only thing that's important. And I think that's really important as we look at COVID. The reality is that for a lot of people, COVID is one of many sources of danger. It is one of many sources of threat to family and to livelihood. And actually, the shutdowns and the other activities that have happened can be just as dangerous as the disease itself. Also, depending on the environment we're working in, when we talk about the US, the UK, I'll limit myself to places I've lived, but we're seeing a similar thing across many countries. Really, COVID-19 is one of the few times in adult history that simply going to the grocery store, simply going to libraries, simply going to work, living your normal life, you could come in contact with a communicable disease that could be lethal. Now, there's still a lot of information coming out about how lethal it is, about how easy it is to contract it, all of that. But the idea, the concept that you could, going about your normal life, have an interaction and obtain a communicable disease that you could die from was a very new challenge for a lot of Americans and Europeans. For a lot of places around the world, that's a reality they've lived with every day their entire lives. And so we have to be really careful as we step into these environments to listen to the communities that we're working with, to talk to the leaders of the places that we want to help, to come in and say, what is it that you need? What can I do to be helpful? What is the plan that you have? What are the priorities that you have? And how can we contribute to that? So that we're not simply coming in saying, okay, this is the problem. I've got the solution. I know what I want to do. And that's a really important part of this discussion. So that's one piece that I wanted to look at. There actually is one other piece where Bill talks directly about what is going on with COVID in the DRC right now, and so that's where he is. And so just want to give us a chance to hear one more segment, and we'll transition from there and really looking at how we respond to COVID along those same lines.
No widespread panicking here in the Congo. People have lived through outbreaks of cholera, malaria, measles, and this is just one more. There's of course no hoarding and no lines at stores, as few have as few have the expendable income needed to buy things to stock up. People are basically living day to day. But there has been widespread acceptance of basic public health measures such as wearing a mask, frequent hand washing, social distancing, contact tracing. Those are all commonplace and common practices. However, I think that our biggest challenge, certainly here in the city of Goma, is the lack of isolation beds. There are no COVID beds here in the city of 1.1 million people. We are just now talking about repurposing some of those, beds from the Ebola outbreak. But those are 30 to 40 beds here in the city. We're now seeing 200 cases per day here in the DRC.
Wow.
The other challenge is, of course, asking people to self-quarantine at home if they're asymptomatic. Well, that may be practical in the U.S. where people have bedrooms and doors and they get closed, but how do you quarantine in, humble homes where there might be one room, two rooms, where there's eight to 10 to 12 people per household? So certainly, quarantining at home will certainly mean infecting dozens of others. In terms of healthcare, we don't have the ICU beds. We certainly don't have ventilators. I think we've got 4 or 5 in the city of 1.1 million people. But we don't talk about a mortality rate of 5 or 7%. What does that mean to a population where actually, here in the DRC just a few years ago, the average life expectancy was 50 years old. So I came in when I was 22. I'm almost 64. I'm an old man in this country. So, for some, a 5% chance of death may mean a 5% chance of seeing one's redeemer sooner than expected. But don't get me wrong. No one in this country wants to die sooner than they have to. But in my opinion, the fact of dying for the individual doesn't carry the same fear or the same anxiety as perhaps in Western cultures. So lastly, we talk about quality of life, not quantity. Health of the family, health of the local community, keeping people employed, schools open, having access to food and sufficient water, especially in a context where airports have closed, the borders have shut down, and where imports to Africa, the lifeblood for many, have dwindled as prices have escalated. So our fear and the things that keep me awake at night are the lack of food, the lack of water, the lack of medications, the lack of vaccinations. These things may end up claiming more lives on the African continent than the virus itself, in my opinion.
And that's feedback that I've been hearing from a number of contacts. I've been talking with our colleagues in Rwanda and Ethiopia, and while they both applaud the work that's being done by their governments to limit the spread and to be careful about not overwhelming the already fragile healthcare systems, it definitely is a concern that businesses shutting down, even as we've experienced, we're small business owners here in Washington State in America. We have the same thing, but even more so in places where there are fewer safety nets, where people don't have as much in savings, where there are fewer opportunities to access those additional resources. Many of you probably saw the video on the BBC talking about the impact in India when they first shut down. This is really a common theme throughout the world, is how do we manage both saving people's lives from disease and saving people's lives from hunger and starvation and other losses that come with a loss of livelihood, with a loss of infrastructure, with a loss of supply chains. And that was something that Bill hinted at towards the end of that discussion was, hey, what about the supply chains? What about getting medicines? What about getting food? In a lot of different African countries, the needs are going to vary. Each country has its own challenges, its own resources, its own supply chains. But in many sub-Saharan African countries, we're looking at over 95% of equipment and medical supplies are coming internationally. And so that was really the last question that I wanted to talk about today. And I actually brought this up in the discussion that was taking place to really say, how do we manage supply chains? How do we look at the needs in order to make sure that we are getting the supplies through? And what is the balance there between supporting local supply chains and really bringing in that international experience and the global supply chain strength that can come, but also the dependency that comes with it? And so I really appreciated the answers that we got from the team and wanted to share those with you as well.
You can go Google that. There's some good stuff on that.
Mhm. Bill, would you
So,
like to comment?
yeah, so Mike, that is a good question.
Yeah.
Great. Thank you. Thank you so much. We have a question from Caitlin Morse at
Here we go.
MorseCode Medical.
Getting there.
She says, in healthcare, to what extent should international organizations bring in their own supply chains into fragile settings and crisis settings, and when should they try to support the local supply chain? Um, Lance, why don't you to start with that? And I see Bill smiling. I think he would like to answer if we have time. So we're
Yeah.
very close to the end of the hour. So go ahead, Lance.
Okay, that's a loaded question. I will try and tackle that. I will confess I haven't mastered this one, but I think a lot of times early on in a disaster, a lot of local supply chains are disrupted. I mean, that's why it's a disaster. They're calling in, they're making an appeal for international assistance, and so I think early on, oftentimes you do have to be self-reliant and bring in establish your own supply chain. But I think you have to be very, very sensitive to the local community. The last thing you want to do is start to create a parallel system that's not sustainable. You don't want to interrupt local markets that are heavily reliant on commerce. And so, as one of the other speakers already alluded to, it is critical that when you engage in emergency work, that you're doing so with the nationals, with the local community. And I would say as soon as you can, you really want to start relying on local supply chains. And that's hard to do, but that's something that I think it's critical just from the start if you can really have great communication, over communicate, and really one thing that we do is like with our medical staff, we immediately start trying to bring in national staff to working side by side so that we can have these conversations about reestablishing local supply chain and things like that.
Very
Debbie,
good.
Debbie, I would agree with Lance. Unfortunately, it certainly is necessary in the crux at the outset to bring in our own supplies, but we should not exit without making sure that the local supply chain is there. Certainly, health system strengthening is one of the things we do best, and it's one of the things that we can leave behind. So it's great that we can come in. It's great that we can, bring in our own people and supplies, but we shouldn't leave until the system is fixed. And that's really, I think, great organizations like Salesforce, World Vision, IMA, and Lutheran World Relief, we do that very well, and we take it very seriously. As does SIM, Debbie.
Great, thank you so much.
So one of the things that Lance talked about was how quickly you engage not only with the supply chain, but with medical staff locally, right? And that's something that a lot of organizations have taken a much better approach to in the last decade and have really said, hey, it's not enough to just come in and do the surgery and provide the relief. We actually need to be doing more training than we are delivering services. We need to leave behind more capacity among the teams, among the staff, among the surgeons, among all of those that are involved than there was before we came. And I love what Bill added from IMA on the supply chain side, which is we see the problem that when foreign staff come in, they also bring with them their foreign equipment, their foreign supply chain. And so when it comes for them to leave, for them to back off, it's not just that are the staff trained, but it's do they have a supply chain to actually get those supplies? So let's say there's a piece of equipment that's been donated, but it needs ongoing disposables for each patient, right? Whatever's touching the patient should be replaced with every patient. How are they getting that supply? Is that something that can be developed through local distribution? Is that something that's being manufactured locally? Is that something that they can actually get access to? And so it's important when we talk about humanitarian response in the same way that a decade or two we were talking about, don't just go fly in a bunch of rice and destroy the rice farmers' local market. We have to be looking as we deliver healthcare. Of course, in those first days, we're going to have to come in and respond with supplies, whatever we can get that may or may not be available locally. But as the local supply chain starts to get back on its feet, how do we make that transition to ensure that in trying to build that support, we don't actually destroy the local ecosystems and the local health care supply chains that already exist, and really make sure that we're providing that support in a way that is not only concerned for those individuals that need the care, but is also investing in those who are going to provide that care long term. And I think that's a really important point to be made. So there was a lot of good conversation in this session. Feel free to go and have a look at CCIH. I'll put all the links below for how to go see that whole session. There's another 2 sessions this week that are happening around the topic of humanitarian response. And one of those is even going to look a little more at this question of supply chain. So check that out. Hopefully you'll be able to join in on that on Thursday. And I will keep the videos coming. If you haven't seen our other videos, this is day 4, so you can go back and catch up and get some quick highlights from the previous videos. I would love to hear your comments if you watched that whole session, so what things stood out to you the most. And if you didn't have a chance to watch that, but in watching this, you have more questions about supply chain, about how some of these things are handled, about what a Christian response should look like in humanitarian crises, and really in general, what ideas you have around health system strengthening. I would love to hear your feedback, your response. If you're doing something in a low resource environment that is involved in health system strengthening, please share that information, reach out. We would love to talk to you, and looking forward to seeing you on day 5. Thanks. Bye.